So let's start first, and I'll start first, Shaw, with you. What have been your biggest surprises due to COVID-19?
I think a few things that we recognize as surprises were, one, really how quickly the referral sources stopped on-site presence. So it was like one day you're there servicing the referral, and then the next day, literally, it was, you can't come. I mean, obviously we had to adjust and use technology to still accommodate the orders and the service levels, but it really was like a next day it happened. You know, one of the other surprises I think that we really saw as well was referral sources not adapting to technology for their own practice. You know, like in sleep centers, not moving to telehealth and not moving as quickly as I really thought they would have to maintain their business. And some even today, 2 months later, still shut down versus actually enabling themselves to service the patients. And those are some of the biggest things we saw. One other surprise to me, I think, and to a lot of us in the industry, was how poorly some of our providers in the industry reacted to some of the changes from COVID, right? We had relaxation in some of the policies to help service patients, and they really used that to capitalize on getting orders and marketing to patients and providers in a poor way. Fortunately, it reflects badly on all of us as an industry, right. But I know the vast majority did the right thing and continue to do the right thing through the process.
Great, good. That's great feedback. Josh, I know you had you know, the hotbed area of Detroit. You certainly have that, and so what were some big surprises that came from that? I mean, as you think about treating that area and how you handled your employees, et cetera, sort of talk to us a little about that.
Sure. Thanks, Rob. And before I jump in, I just want to give a shout out to all our essential workers, doctors, nurses, first responders, respiratory therapists, medical equipment technicians, hospital liaisons, everybody. Thank you guys, and you guys are definitely the heroes. So thank you, Rob, for giving us the platform to talk about this. Some things that we saw that were really interesting and challenging. We operate in 7 different states, and so similar to Adapt and Shaw's business, there are different challenges in different markets. But one of the things that was interesting for us to see was each state had different policies that they rolled out. They had different proclamations, different mandates. The health departments for each governor had a different idea on how to control this. And so for us, as we looked at how we could maintain business continuity at medical service company, it depended on the state. And it wasn't necessarily medical service company's best practice or desired direction at that exact moment, but we would zig and zag with each state. So a couple examples: Michigan and Pennsylvania require us to check the symptoms of all of our employees before they report to work. Indiana and Ohio require us to submit our ventilator inventory to the state on a weekly basis in the event that they need it for acute care in the hospital setting. So those are just some examples that challenged us. And you know, we joked a lot as a business continuity committee. We met every day, and we felt like in the first 6 or 7 weeks, every day was about a week's worth of decisions, with things moving quickly and things being managed to the state degree and then to the county degree too.
Sure. No, that's good. Great feedback there. Josh, this next question is a two-part, and I'll start with you. So as you look at it now, how many COVID-19 patients are in your organization's care right now? And then a follow-up to that is, because I think everybody is you know, trying to understand, are we seeing a flattening? Is it starting to slow down as far as patients in care for the home care provider? So talk to me a little about that.
Yeah, so like you mentioned, Rob, we've got a significant presence in Michigan and primarily in the Detroit region, which is where we saw a hotbed. If you know, watching the news and reading, you see Detroit coming up for those reasons. Throughout the last 8 to 9 weeks, we've cared for upwards of 1,000 COVID confirmed patients throughout our network, and those span from over a dozen different markets. So Michigan was the largest, but we saw patients in Indiana, in Ohio, in New York. So we're feeling it all over the place. As far as what that curve looks like, in April, we saw it climb, and we saw it climb fast. It really, it hit us in the mouth very, very strong. Towards the end of April, and fast forward to where we're at today, it certainly slowed down. We are onboarding several new confirmed COVID patients every day, but it's not the dozens per day that we were doing in April. Our concern is, as states are opening up, which understandably so, business and commerce needs to carry on, there is going to be a direct correlation to the virus spreading more once people are out more. And so it won't be the same surge that we felt in April, because there's social distancing and other protective measures, like many people wearing face coverings and things like that. But we are very guardedly cautious to know that this isn't behind us, and until there's a vaccine, we'll continue to care for these patients on a daily basis.
Yeah, well, in one sense, I think it's good that you're seeing some flattening, but I think at the same time, it's so important to keep your guard up, right? So if you do see an increase or a resurge, that you're ready to handle it. Shaw, AdaptHealth is obviously a nationwide company, but you had some real strong areas or hotbed areas: New York, New Jersey. Same questions for you. How many patients do you still have in care, and sort of that same flattening or slowing down? Talk to us a little about that.
Yeah, we've right now to date serviced about 2,000, just over 2,000 COVID patients at AdaptHealth. And we continue to see a fairly high trend. We did see some flattening in certain areas, but just because we have presence in so many different locations, we've also now seen spikes coming in other areas as the hotbeds kind of move around the country. Being in New York, I think we got hit pretty heavy in the very beginning. New York's one of our biggest presence as a company, and New Jersey and Pennsylvania, all of which were really the hotbeds in the beginning. So we got quite the kickstart into the process. I think as a company, though, we also took a little bit different approach, and we actually started helping the hospitals manage COVID in some of the hotbed areas. So providing them or partnering with them for beds and oxygen and vents to be able to actually help them in the process of the discharge of the patient. So that's just a different approach we took in the beginning, just because of some of those relationships, especially in New York and New Jersey, which is definitely what has become the epicenter of all of this growth. We do expect, I think even as a country, expect we're going to have another rise. So one thing, at least from this, I think now we're much better prepared to handle it when it comes. I would say everybody is taking what we've learned from this and just now set it up for the next wave, because unfortunately I'm pretty confident that we're going to have it. Hopefully not as bad, but it's right. I think everybody says it's inevitable.
Yeah, no, I think it's good that both of you talk about, and I think it's important for all HME providers to make sure they're prepared, because I think we're far from having this behind us, unfortunately. Shaw, as we think about treatment plans, because I think this is important for all providers to understand, we certainly have heard of equipment shortages, but needs of concentrators, beds, ventilators, other supplies. But what treatment plans do you have for those COVID-19 discharges or other patients or other COVID patients in your care? Sort of what is that process, and what equipment are you utilizing there most?
Yeah, so we're generally seeing oxygen, right, is the main treatment that we need to do as part of this process. We did a lot of partnerships with doing POCs out of the hospital to get the patients home in a quicker fashion and give us more time to get there and set up a longer term solution if needed. What we're finding is a lot of times the longer term solution isn't needed. The oxygen levels aren't high, and it really is a POC for the matter of, 3 months, 2 months, 1 month. I think that's the problem we don't know, is what the length is going to be on those. When we look, I think we're all going to run into some issue of saying, how do we end the cycle, get the equipment back and recycle and go through the whole process of disinfecting it and starting over. But POCs has been a more positive way, I think, to help discharge faster for most cases. We've been lucky in the fact that we haven't had any shortage of equipment, so we've been able to do all modalities of oxygen for the patients, but definitely seeing POCs as the higher area in focus.
Good, interesting. Josh, how about for your team and your organization?
Yeah, it is interesting when I talk to friends that are outside of the industry, and I tell them that virtually none of the patients that we take care of require a ventilator. It's just surprising because that's what you hear about.
Right.
And there are certainly shortages of ventilators in the HME channel and also obviously in the hospital channel. But like Shaw mentioned, about 9 out of 10 of our patients are on oxygen therapy. One thing that we observed that's very interesting is early on in late March and early April, the oxygen that was being prescribed was pretty traditional, 2 and 3 liters continuous. And then as the surge really ramped up and the hospitals started having less and less beds available, we saw the oxygen prescription change to a higher liter flow, which what that tells us is patients are being discharged faster in an effort to free up more space in the ICUs for more patients because of the surge. Yep. So through April, we saw those higher liter flows, and now fast forward to where we're at today, we're not only seeing more traditional liter flows being prescribed, but we're also seeing more general DME being prescribed either as well or instead of, which again tells us the hospitals have more capacity to take care of that patient, let them work through the virus and those really challenging symptoms and wean them off of oxygen therapy in some cases, where at this point about 8 out of 10 of our patients are on oxygen. So just an interesting thing to kind of map out as we see the peaks and valleys in different markets.
Yeah, and I think, you both sound like you're in a pretty fortunate position where you're not seeing equipment shortages, right? You're able to handle that. We certainly talk to providers all over the country. Some are experiencing that. As you went through this, and people are going through it now. So how did you decide sort of who received that equipment, Josh? Because you have these long-term oxygen patients, right, that you've had for a very long time in service, and you have these referrals that count on you. So, and then all of a sudden you have the hospitals and health systems hitting you and wanting you to partner with you and get products. So how did you go through that process, making those decisions? I think that's important for other providers to consider. So I'll start with you, Josh.
Yeah, well, first thing I'll do is I'll give a shout out to our logistics team and our equipment sourcing group. We, I would say, scrubbed through the Rolodex to make sure that we had all of our vendors in the loop as far as what our needs were. And we didn't have to turn away any oxygen patients, whether they were confirmed COVID or not. I think what the challenges were twofold. Number one is just because you have the inventory in one part of your enterprise, it doesn't mean that it's in the right part of the business to serve the market that's in need. So, that was a significant challenge, and leveraging our inventory, the technology that we have, and just our committed team to get equipment from point A to point B at the right time is really what was important for us. The other challenge that we all have is, even if and when you can get the equipment, it is at a premium in price. So, we're paying 30 to 50% more for this equipment than we were previously. And the reimbursement's not changing. The profit logic is probably worse because, like Shaw said, this is going to be short-term oxygen, 3 weeks instead of 3 years. And it's the same cost to pick up and deliver the equipment regardless of how long it's out there. So we're experiencing other headwinds that we have to work together as an industry on to thwart and to impact positively. So we know competitive bidding is around the corner, January 1st. As an industry, knowing that pricing is going up on sourcing equipment, the service to do it is more expensive because of the PPE. We really need champions in Washington and throughout the nation to get competitive bidding stopped and find a more sustainable reimbursement model. So all of the groups are doing that, and I would just encourage everybody to be a part of that.
No, I appreciate it. Appreciate the answer. I think there's a lot of ways right now, or a lot of companies that are experiencing these shortages, and I think that's good advice on sort of how you do that. I'm going to switch gears a little bit and talk a little about technology. I consider your two companies to be very innovative when it comes to technology. So, Shaw, how are you leveraging new technology approaches, and as you navigate really patient care and reimbursement? What are you doing differently? Because there's been a lot of changes to how reimbursement is being done, and some of the things that you're able to do now with face-to-face, et cetera. So talk to us a little about that and how you're leveraging technology.
Yeah, from just the initial patient care perspective, PAP specifically, we quickly moved to telehealth setups. It was something that we did previously, but maybe in a 20% manner, and now we're more in the 80% range of telehealth. Probably something that a lot of organizations will continue with after the fact as well, because we're seeing fairly good success with compliance post telehealth setup as well. So we implemented Zoom technology to do the actual telehealth setup, and then DocuSign, which we actually integrated into Brightree or API'd into Brightree. So we're able to get all of our documentation as well from a billing perspective, all within that one setup process.
So you're doing, I'm sorry, just to interrupt to understand, because telehealth is a word that's being used for a lot of different things. So when you say telehealth, you're doing that actual for the setup. So you're doing the Zoom training, you drop off the equipment at the patient's home, and then you set up a Zoom. Sort of walk us through that process.
Yes,
or that.
we actually drop ship most of the equipment direct from VGM that configures it to the patient. And then once the patient gets it, we set up a Zoom session, and we go through the entire education process, setup process with the patient through Zoom. We do have some other technology options as well that we use, but Zoom is definitely the primary one and seems to be the most successful because it's very user-friendly. So it's been good from a patient's perspective, from a user side. As part of that process, we also go through the entire delivery ticket documentation process, everything that we need to be able to bill from the patient's perspective as part of that process. So by the time we end the setup session, we've actually got all documents signed back and put into Brightree and ready from a delivered and signed perspective through our telehealth setups. So no sending documentation after the fact, which is what used to happen. We'd send the papers after the fact and say, okay, we did your setup, and then you're chasing to get them back.
No, exactly.
And it's been great with Brightree and our development team, because we've been able to actually take that documentation from DocuSign and load it directly into BDM now. So it's automatically in the system available for our teams to use. We also pushed very heavily on electronic orders. Heavily used Parachute, heavily used GrowScripts today. And so really pushed into the referral sources that were maybe a little bit more objective to it prior, or not as a little resistant to it prior to the COVID situation. And now they see the benefits of it. So we broadly expanded our electronic ordering through that process. And also took some maybe alternative approaches of allowing it to fax into our electronic ordering system, and then we communicate back out to the physician through that system to help, again, drive that communication. Because when you're not there face to face, the next best thing is that they can look at the application, say, okay, here's the order process, here's where it's at, right? Not sitting there calling back and forth, trying to understand where that is in the process. We also, I think, like most organizations, we moved to an at-home workforce. So we did it in the matter of a week. We moved about 3,000 of our workers home using a desktop as a service solution, and then a telecom solution that we had been working to implement for about a year, and fast-tracked the rest of it to happen. Interestingly, though, I think what other organizations are probably seeing as well, we're actually seeing better productivity. We're seeing a lot of better service levels actually from call volumes and answering and responses, which is, questionable of what you see or wouldn't see. So the dedication of the staff didn't change when they went to work from home. A lot of that being there's visibility in the tool sets that we use. But you could tell there's still that clear commitment. It's more than a job. It's the team really wanted to be able to serve as the patients at home, and be able to handle that process after go live as well, or after moving home from COVID.
Sure.
So we've really tried to capitalize on technology just to maintain service levels. And actually, I think what we're going to end up seeing out of it is improvement.
Yeah, no, that's fantastic. And I think that's a great lead in, Josh, to sort of, I think there's going to be changes, right? We talk to providers all the time, and I think there's been such, through this tough pandemic, probably a lot of good learnings have come, right? And so what are some of the learnings, and Shaw hit on some of them, but what are some of the learnings that you think will be different moving forward for your business, and how you treat patients, and how you treat your referral sources, and how you interact with both?
Yeah, it's a great question, and there's such a speed of innovation with how different platforms are being leveraged now in a work from home standpoint. Like Shaw mentioned, the big takeaway for us is, we're going to continue to take care of patients the way that we always do. We're going to drive outcomes for our partners. We're going to bring value. We're going to be a difference maker. And so I think all of that is somewhat going to remain intact. The pieces that we will carry forward most significantly that will impact our business is how we take care of our people specifically. So, we talk about working from home. Most of our people, they want to work from home. Like Shaw said, in large part, they're just as productive, if not more productive, and they're wearing their fuzzy slippers, and I'm okay with that. So if our people can work from home and be productive, then they should be able to do that. So, that's one of those big takeaways. With working from home and having a remote workforce requires a lot of communication. And one of the things that we are very proud of taking on very early on was sending out daily emails to all of our staff. As soon as we sent our team home, people are wondering, what does this mean for our job? What are benefits going to look like? What happens with taking care of the kids? Is your 401k changing? I mean, all those questions that you could walk to our HR leader's office, that goes away, and there's just way more speculation. So daily communication with our team was very important and is very important. We have weekly video webinars with our management team to make sure that they're engaged. And we even held our annual meeting virtually on Microsoft Teams, a live event a couple weeks ago, and had over 200 people from 7 different states present. And it's just one of those things that you don't want to stop the show just because we're in this public health emergency. You got to keep powering forward and find a different way to do things. So the communication was really important for us. And then the final thing is speed. And so we've really embraced the saying that you don't want to let perfect be the enemy of good. And like Shaw mentioned, you get thousands of people at home, and the same thing for us. We had hundreds of people that we got home in 3 days. And that was done by taking a fast approach and making sure that 80% of the challenges and perceived bottlenecks were buttoned up, but there was still 20% out there that we weren't really sure, is this going to work? Are they going to have connectivity here? How are we going to do this? And you figure it out. But for the safety and the security of our people, for our patients, for our communities, taking that calculated speed-based approach was really important, and something that we're going to make sure that we continue to utilize.
No, I really believe that with any challenges comes opportunities, right? And I think you both hit on some key areas on how you're going to treat your employees, how you're going to treat your patients, and how you're going to treat your referral sources going forward. And I just can't thank you two enough for joining. I think there was some great information that was shared, and again, we appreciate you being on with us.